Today is another one of our now series of Hollander Rounds, so named after Harry Hollander, who is here in the audience. Harry was residency director for a generation and trained many fantastic UCSF residents who've gone on to illustrious careers. And so we were thrilled a few years ago to be able to name these clinical problem-solving cases after him because he's done so much in this area for all of us. The ground rules for these clinical problem-solving cases are up here. The discussant is blinded to the case. The goal is to learn how an expert discussant thinks about a tricky case. Not necessarily to get the right answer. It's nice if they do, but that's not the point. The point is really to learn about the thought process and how we do diagnostic reasoning. They're not magicians. They don't have to know everything, although I think it's probably useful that they know something. It's about the journey, not the outcome. And we encourage active audience participation. And since our discussant's a pulmonologist, decent chance that it has something to do with pulmonary disease. I see a fair number of our fantastic pulmonary colleagues in the audience. So if you have thoughts, feel free to weigh in. We should have time. And this should be fun for all of us, for me at least, for all of you. And I think for the discussant, I'm hoping. So our discussant is... let me pull up my little cheat sheet. So our discussant is Erica Farrand, who is associate professor in the Division of Pulmonary, Critical Care, Allergy and Sleep Medicine. If they add any more titles, that'll take the entire hour. Erica's work focuses on improving the quality, safety, and outcomes of care in patients with interstitial lung disease through digital health and multidisciplinary collaboration. And really a highly respected clinician and educator and researcher as well. And so, Erica, why don't you go ahead and stand up? And thank you for being here. We'll take a little applause to start. And I think this is the first time you've done this. So any preliminary thoughts as you're standing there?
Kindness and grace.
That you are going to bestow on us or that we should bestow on you? Both bilateral kindness and grace. All right. It's a nice way of starting things. So let us go ahead and get started. All right, we'll start with an HPI. A 52-year-old woman with hypothyroidism, hypertension, and psoriasis is seen in our pulmonology clinic for 6 months, history of cough, dyspnea on exertion, and substernal chest pain. And we will let you stop there. And the question is, how do you approach dyspnea on exertion? But you can also go back and look at that and see any preliminary thoughts that you have when you just hear the chief complaint.
Dyspnea on exertion and cough, probably the two most common reasons why someone comes to an outpatient pulmonary clinic. And both are very, very non-specific. So I think generally we're starting by asking ourselves, is there a respiratory cause or contributor to these symptoms? And if that's present, how big of a role is that playing? And so it requires us to really kind of step back and put on our internal medicine hats, I think, and think really broadly about the causes of both cough and dyspnea. And I think I'll probably focus on those two, guessing that this is probably going to be going in a pulmonary direction. Cough being very nonspecific, but when we think about it, we're thinking about respiratory causes, we're thinking about GERD, upper airway etiologies, and really wanting to flush out to what extent those causes may be present in any given individual. And then dyspnea on exertion, often one of the big areas that we want to interrogate outside of the lungs is the heart, and thinking about sort of cardiac risk factors that a patient may have, how active they are. So dyspnea is really on exertion is going to be dependent on how much somebody moves around. And so it can be really, somebody can say, I don't feel short of breath, I don't have any dyspnea, but they're spending most of their time sitting still. And so I think getting a sense of how active someone is on a day-to-day, when they started experiencing the dyspnea, how severe that dyspnea is, helps us to understand how much a respiratory cause may be contributing. Maybe I'll pause there.
And I guess I tend to think in Venn diagrams. If let's say you're queuing in on dyspnea on exertion, the presence or absence of cough, does that narrow your differential? For example, if you is in the back of your mind you're saying, if this was heart failure, I wouldn't expect there to be a cough, but if it was lung cancer, I would expect there to be a cough. How do you think that through?
Yeah, that's a great question. I think I think about interrogating those things separately to try to understand how big of a cough is, how big dyspnea is. And then if there's an intersection, you're right, it may help me to narrow things, that differential down a little bit. So if somebody has a primary respiratory issue, so with my ILD hat on, if they have cough and shortness of breath, certainly ILD is going up on my differential, and something like heart failure may be going down. But I don't think neither of those symptoms are specific enough for me to really rule anything in or out. And I think both of them, I still have a pretty broad differential that includes many things outside of the pulmonary space, based on those two alone.
So I guess you could probably sometimes will see a cough in patients with heart failure, maybe less common.
Yes. And again, because the cough can be due to many other things that are common, right?
Yeah.
Find a patient that doesn't have GERD that also has, psoriasis, hypertension, hypothyroidism. Many patients have other reasons for cough. So those two symptoms alone, I think are really, really broad, really, really nonspecific. And I think we try really hard not to anchor on a respiratory cause alone with those two symptoms only.
Right. I can imagine, for example, if it's from anemia, that you would be surprised to have a cough, but beyond that, it probably is premature to narrow too much. Okay, great. All right. 7 months before this admission in December 2024, the patient had numerous ill contacts and developed the cough with yellow sputum, chest congestion, tactile fevers, and mild shortness of breath. She was prescribed Augmentin, prednisone, and an albuterol inhaler by someone in local urgent care. But the symptoms didn't improve. In January 2025, the patient was seen at her local ED, where she was prescribed azithro and maybe again Augmentin. A CT was taken then and showed atypical bilateral peripheral predominant infiltrates. The antibiotics, steroids, and albuterol didn't help. The dyspnea on exertion persisted. All right, so I'm happy to go back if that's helpful, but the question is, how does the timeline, this is now taking place over a couple of months and doesn't seem to be getting better with some standard therapy. So how does that shape your differential? We'll go back right there. So first presentation, December 2024, gets an antibiotic, prednisone, and inhaler, and then a month later. So we're talking 6-8 weeks of symptoms at this point.
My pulmonary colleagues can attest that this sort of presentation is so common regardless of where you see us in a pulmonary clinic. The combination of antibiotic, steroids, and inhaler is like this trifecta that tends to be thrown at patients for first line. And I will say it does give us a lot of information if someone doesn't improve, right? Like if you have a community acquired pneumonia, you should improve with multiple attempts at this approach. And so the fact that someone hasn't, we have to step back, and either we've gotten the diagnosis wrong, or we've only partially treated the correct diagnosis, or it's more complicated than we think. And all of those things we sort of have to consider here. So I'd say particularly the time of year, December and January, respiratory illnesses, viral illnesses, bacterial illnesses are circulating. And so an infectious cause is quite possible and very common cause of this type of presentation. And yet, having been treated for CAP, it sounds like at least a couple of times, gotten steroids for an inflammatory contributor to those symptoms, and an albuterol to help with any airway constriction without improvement makes us think, well, maybe this isn't infectious. I'd like to know what the steroid courses were and how long the patient got steroids. That will help me to understand if I think that this is potentially a steroid responsive process. Did I just not give enough steroids? Did I not give it long enough? Or did they get a real trial of steroids and did not respond? That gives me very different type of.
And when you say what would a real trial be that would tell you, okay, this may not be a steroid responsive thing, how long and how much?
It's a great question. I think what we often see is somebody gets 5 days of 40 of prednisone multiple times, right? And so that kind of gives us, that's what we normally think of sort of supporting a more complicated infectious course. For most steroid responsive inflammatory processes, they're not going to respond they're not going to have a sustained response to 5 days of prednisone. So understanding, like, did the person feel better with 5 days of prednisone? Did their symptoms get a little bit better and then they came back? Or do they really not feel any different with that course of steroids alone?
Okay. And you have a CT read here, not with a whole lot of detail, but what do you make of that? Atypical, bilateral, peripheral, predominant infiltrates. Syntax isn't great, but beyond that, what do you make of it?
Yeah. Okay. So this tells me, I think, the peripheral predominant infiltrates, I don't know whether that means this is inflammatory versus fibrotic. So that's the first big thing I want to know, right? That gives me a sense of the type of injury and the timeline of injury that's happening. If it looks like it's just inflammatory, I'm going to be thinking about going down a different pathway than if there's evidence of scarring on that CT scanning as well. So the infiltrates word, I think we need to kind of interrogate a little more. I'm interested to see the images for myself to understand. I think the fact that it's bilateral and peripheral, so that makes me start to think about, I mean, I'm obviously biased, but thinking about interstitial lung diseases where we often see injury showing up along the periphery of the lung as opposed to central or airway predominant processes like we would think about in an infection.
Any reason, do we know why that happens?
Well, I think
to be peripheral?
some of our more common interstitial lung disease, just the radiographic pattern tends to show up on the periphery first and move from the periphery inward. That's not true for all interstitial lung diseases, but certainly seeing things along the periphery of the lung makes me think of a process that's driving it that's separate from an airway process. So that's starting to come into my mind. And then I think, again, the fact that it is bilateral, so we're thinking about more than we're thinking about a more diffuse process, right? So it's happening on both sides of the lungs. I think that's all I can really take from that.
Okay. I'm having a neuron flip from 50 years ago about an explosion at the hilum that goes out to the periphery is, I think, classic for something, but I've forgotten what. Maybe eosinophilic pneumonia. Does that sound familiar?
Yeah. So I think with acute eosinophilic pneumonia, we tend to see bilateral ground glass opacities. Chronic eosinophilic pneumonia, you see more of that peripheral process. So both of those things would come in. But again, I think understanding, really interrogating what this infiltrates word means, whether we're talking about inflammatory, fibrosis, or a mix of the two, will really be helpful in trying to narrow our differential a bit.
Right. And does the bilaterality change the probability it's an infection at all?
Oh, well, I think not really. Bilateral makes me think more viral than it's going to think bacterial. But I think in terms of mimickers of primary pulmonary processes that are not infectious, we're often seeing, a viral pneumonia would be the most common. And so that would remain in the differential there.
Okay. So, but the fact the person hadn't seemed to get better on antibiotics and bilateral, and we'll see kind of what the infiltrates are, but maybe lowers the probability this is all a bacterial. This is all CAP. Okay. All right, more history. 5 months before this admission, so around April 2025, so I guess about 5 months into the disease course too, the patient developed rapid worsening of her dyspnea, for which he was admitted to an outside hospital. Chest CT and angio at that point re-demonstrated bilateral ill-defined peripheral, now ground glass opacities. The patient was afebrile and satting well on ambient air. She had no leukocytosis. She was treated then with prednisone 60 milligrams daily started, which was tapered over roughly 8 weeks. By 3 months prior to admission in June, the patient had minimal improvement of her dyspnea despite those steroids. She'd started desatting with ambulation and began requiring 3 to 4 liters of home oxygen. She was enrolled in a pulmonary rehab program, and PFTs were ordered by her primary care doctor. And before I show them to you, anything you want to comment on what you've seen so far?
Well, it sounds like she's gotten a real trial of prednisone, right? She's, we don't have a weight on here to understand like weight-based dosing for prednisone, but prednisone 60 milligrams is going to be a pretty significant dose for many patients. Tapered over 8 weeks, I'm going to assume that she got at least 40 to 60 milligrams of prednisone for, 2 to 3 weeks of that. So that's a real trial. Again, like tapering the actual script of the prednisone is important for us to understand how long she had exposure to high dose prednisone to assess her responsiveness. But overall, it feels like she's had pretty significant progression of her symptoms to the point where she's now requiring oxygen. We're thinking she's debilitated enough that she's going to benefit from pulmonary rehab. She's been admitted to an outside hospital, and none of the things that we have thrown at her thus far have really changed that disease trajectory, right? Including high dose steroids, multiple courses of antibiotics, and an inhaler.
And in terms of disease, the fact that, let's say she got 60 for a month and then they started to taper, does that change the differential diagnosis of what it could be? Or it just, there are certain diagnoses and sometimes prednisone works and sometimes it doesn't. It actually doesn't really change the list.
Yeah, I think for us to really know whether we think prednisone working, again, is kind of knowing what the dose was, how long, whether the patient was taking it. But yes, there are things that we expect to be very steroid responsive that this description of her disease course would not align well with. So things that come to mind would be an acute eosinophilic pneumonia or chronic eosinophilic pneumonia, both of which are very steroid responsive processes. They may differ in how long you have to taper the prednisone or the likelihood that the symptoms will flare again during that steroid course, but we would expect responsiveness to steroids up front. Other things that we would expect responsiveness would be something like an organizing pneumonia. These are very steroid responsive diseases. And so when you hear a script like this, it makes those processes less likely.
Okay, great. That is very helpful. So same thing. So now she's clearly worse, requiring oxygen, pulmonary rehab, and she gets these PFTs. And so the next slide just says, how would you interpret them and why are the lower limits of normal now the preferred way of reporting PFTs?
Okay, so what we're seeing with her pulmonary function test is this looks like it's a restrictive process with a reduced DLCO. So the way that we are looking at, big picture, big take homes for PFTs, we're normally looking at 4 measurements and really 2 of those measurements over time. So FVC and FEV1, we're looking at the percent predicted, right? So both of those are reduced from the percent predicted, and the overall ratio, the comparison of FE1 to FEC tells us broadly, is this an obstructive versus a restrictive process? And that's largely telling me, am I thinking more of an airway process, difficulty getting air out of the lungs, or a parenchymal process, which is going to restrict the ability of air to move into the lungs. So the ratio here is preserved. So we're thinking this is a restrictive process. That's just from the spirometry. When we have a total lung capacity, which we have as well, that is how we diagnose a restrictive process. And so again, we're seeing the TLC is reduced as well. So we're seeing overall, looks like moderate restriction. So patients really having a difficulty taking air in without evidence that there's trouble getting that air out. Okay. And again, when I see restriction on a PFT, I'm really wanting to know, does that CT scan show me scarring? Because my pre-test probability of seeing some scar on the CT scan has now gone up. And then the DLCO is also reduced. So the way I describe this to patients is we want to know how well air moves into your lungs and out of your lungs. And then beside how much air you can get in and out, we want to know how well the air can get where it needs to go once it gets in there. That's what the DLCO is, right? And so when you have scarring in the lung tissue, when you have an alveolar filling process, anything that's making it difficult for the gases to get where they need to go, you're going to see a reduction in the DLCO, or if you have a vascular problem. Those are sort of the 2 big buckets. And so we're seeing both of those things. This pattern on a pulmonary function test makes me worried about there being fibrosis or scarring on a CT scan in addition to inflammation. And then I would say the other thing to your other question about looking at PFTs, we have had a real accelerated awareness of how race-based algorithms can affect our interpretation of pulmonary function tests in the same way that we've understood that with GFR. And so we are trying to, use global calculations to understand PFTs. And I think the other thing that
what does that mean? Global calculation?
Things that take out race, not race specific formulas for.
So in the old days, you got a reading that your PFTs were normal for a white person or a black person.
Exactly, based on if there were enough patients to generate normal values for your race, and that's not true for many races. You would get your predictions based on your age, your gender, your size, and your race. And we recognize as a field that there were lots of challenges to doing that, and that there was not biological reasons to really be driving those formulas. So adjusting the formulas we use, and also I think recognizing that the trend in pulmonary function tests, just like the trend in a CT scan and the trend in many labs, is far more valuable than a single snapshot.
Okay, great. And you said that these overall tell you, this whole thing tells you there's a restrictive disease, and the DLCO sort of gives you a different window into there's something wrong with the diffusion across a membrane to get into an alveoli. Are there times where there's that those are disconnected? I'm trying to think of a case where there's restriction, but it's working fine, that the oxygen's getting in and the carbon dioxide's getting out.
Yeah, so I would say generally when I see both restrictive pattern and a DLCO, there's a severity concern that goes up in my head when I see it paired. Places where I see often what we will see is an isolated DLCO, where that's lower, and actually the spirometry and the total lung capacity all looks normal, and you wonder what to do with that. That makes us think about pulmonary hypertension. And so again, this could mean that there's a parenchymal process and pulmonary hypertension, which generally happens in more advanced disease, or happens in diseases like connective tissue disease related ILDs, where pulmonary hypertension is more pronounced. Or it could mean that the disease is more advanced, that there's more restriction, more scarring in the lungs, and that is now impeding gas exchange.
So the low DLCO by itself with what looked to be normal lung function tells you there's something at the vascular tree?
I normally think about pulmonary hypertension.
Just that, or how about like chronic PEs and things like that?
Sir, okay, you're right. I am like skewed with my ILD hat.
Okay, I'm trying to unskew you.
So if I see just a isolated low DLCO and normal pulmonary, yes, then I'm thinking vasculature in general. So we're thinking about pulmonary emboli, we're thinking about CTEPH, other causes of pulmonary hypertension. You can certainly think about whether or not somebody is shunting.
That's great. I think that's, just to make clear, because it seems like everything is consistent here with the lungs are filled, or something's happening to the lung parenchyma and it's screwing up the ability to get air in and then to get air where you want. But then an isolated DLCO means something very different. That's worth knowing, and probably something in the vascular world.
That's correct.
Okay, great. Yeah, Harry. Hang on one second. Let me just repeat. So Harry asked about someone who develops an infection during respiratory virus season, and at least one of the hypotheses is some sort of post-viral thing. And I guess the question is, would you expect, are there other infections that can do this? What else should you think about? And again, not being steroid responsive, does that change your thinking about it?
I think we learned a lot to that point about in the COVID pandemic about the long-lasting impact that a viral infection can have on the lungs. And I think there's twofold. One, we know that when somebody has sort of diffuse alveolar damage, and again, I guess I have to caveat my comments by saying that I'm not totally sure what the CT pattern is yet, right? Because the description was still quite vague. But if we're saying that we see infiltrates, and let's say that means a mix of both inflammation and scarring in the lungs several months out after, a respiratory infection, that could be that the patient has significant damage to the lungs and they're still recovering. And those patients, really, it is a matter of time, right? The lungs are going to heal. We don't know what the lasting damage is going to be. And we're often just providing supportive care until we see where they sort out. In other cases, an infection can sort of spark or bring to attention an undiagnosed existing chronic lung disease. And so we've seen this a lot in our ILD community, where patients previously undiagnosed with interstitial lung disease had COVID, right? And then several months later, they now have, they're noticed to have scarring on their CT scan, and then that scarring continues, right? And we don't think that that's the infection that's continuing to cause injury, but rather the infection sort of either uncovered or accelerated the progression of an underlying disease. So the timing in December and January for this to happen is by no means surprising. But I think but it's unclear exactly what its significance is, if it's showing us a specific isolated process that we're dealing with, or if it's uncovering something underneath.
You had another question? All right, great. Let us go on. Thank you. High-res CT of the chest was ordered by her PCP, and it shows this. Do you want to say anything? Why don't you say something about that, and then we'll go to the formal reading in a sec.
Ooh. So let's start. I think
Pulmonologist says, ooh, I think that's a problem. Okay.
Well, no, it's more that we're going to go to the formal reading.
You got to get it right. Yeah.
Because I'm going to get fact checked here. So I think we start by trying to I just describe what I see, right? Because I think describing CT images or trying to diagnose from CT can feel very intimidating with our excellent radiologists to lean on. So what I try to do is just say, okay, the distribution, right? So if I'm going from the very top of the lungs to the bases of the lungs, it looks like the disease is more severe at the bases of the lungs. And then if I'm looking out at the periphery of the lung versus in the center of the lung, here it actually looks like there's a mix of disease. And I can't say for sure that there's a peripheral predominance here. I'm actually seeing in the upper lungs quite a bit of central disease, and here it looks more like ground glass. So ground glass meaning like I can still make out the lung architecture underneath, but it looks hazy. That's what I'm seeing in the upper areas of the lungs, and it's both center and out in the periphery. In the middle of the lungs, there's areas of denser consolidation and what looks like to now be some evidence of architectural distortion. So there's reticulation, there's some consolidation out at the periphery, and I'm thinking that there may be some evidence of traction bronchiectasis, all suggesting that this is more of a chronic process because now there has been some remodeling in the lung. And then down at the bases, this does look more fibrotic. So I have both consolidations and reticulations, and I'm wondering whether these, I'm not sure whether that's all inflammatory or fibrosis, but my hunch is that it's a combination of the two. So I think we're looking at a CT scan overall that shows us a mix of inflammation and scarring, but a decent amount of scar.
All right, let's see what they said. Lower lobe predominant, they thought peripheral, maybe different cuts, reticulation and traction bronchiectasis, increased central lobular nodules, nodular consolidations compatible with exacerbation or infection superimposed on underlying fibrotic interstitial lung disease. Okay, by that?
A little bit of everything.
Yeah, a little everything. Okay, okay, so and we need to move along a little bit, but how broadly do you sort of think about the big categories of interstitial lung disease?
I think there's over 200 types. So there's a lot of ways to categorize this. And most of them are just not particularly useful in a clinical setting. So I think in this sort of setting, I'd probably categorize them. And I like to put things in 3 buckets generally. And so in here, I would put them in 3 buckets, right? I would say, because we're not totally sure, this isn't, I'm going to change that. Still 3 buckets. The buckets are first, idiopathic, right? And so that's really a pretty broad nomenclature for a lot of the diseases that we've actually learned quite a bit about. But these are things like idiopathic pulmonary fibrosis, which is the most common, non-specific interstitial pneumonia, some of these sort of more processes which we're not really sure what the clear driver is, and they can cause a combination of inflammation and scarring, but mostly scarring. The second big bucket is autoimmune diseases. So here we're thinking about things like scleroderma, rheumatoid arthritis, myositis, antisynthetase syndromes. And so here I'm really looking for evidence that there's extrapulmonary signal of interstitial lung disease. And then the last big category, which actually has exploded, particularly in the inpatient setting, is things that are outside of the lung and affecting. And that's a really broad category, but in that, I would say things in the environment. So things we know that trigger interstitial lung disease, like birds and down, occupational exposures, and then increasingly drugs and radiation. So a lot of our immunotherapies we know are causing inflammation and scarring in the lungs, so that goes in that category. So when somebody comes in, I'm trying to put them in one of three buckets, and I'm hearing the information they're telling me about risk factors and trying to think about, well, is there an environmental risk factor? Is there a history of autoimmune disease? I'm thinking about the symptoms that they're telling me. The CT scan, again, it has gotten really tricky because we can find all of the patterns that we describe in interstitial lung disease can be seen in almost every single one of those buckets, but certainly they're more likely to be seen one or the other. And so we're really dealing in probabilities here and trying to take all of that information, sort it, and then at the end of the day, rarely are we able to say, not only is this the bucket you're in, but this is your specific diagnosis? More likely, we're just sorting the order of those buckets and thinking about what do we need to do next to make a specific diagnosis.
Great, that's super helpful. Okay, other history, past history, we have hypothyroidism, psoriasis, as mentioned, hypertension, depression, meds, thyroid, buspirone, bupropion, no tobacco, alcohol, or drug use, lives in Reno with her husband and 3 children. Exposure history, which you'd asked for, lives with her husband, 3 kids, lived in Reno for 4 years, previously Sacramento, stay-at-home parent, never been employed as a farmer or in construction, does not garden, nor houseplants or pet birds, no known mold in the house, no known exposure to shipyards, no new meds in the past year. Never smoker, and exposure to secondhand smoke during her childhood. All right. You can go back if you want.
No, can you just remind me the age?
Her age?
Her age, yeah. 50s or so? Okay.
50s.
Okay. I think in terms of exposures, this is telling us largely that there's a negative exposure history, right? The big things that we would think about, I don't know if you've ever read one of our ILD notes, but we really kind of go detailed into the exposures. But the big ones, the themes that come out are like mold and mildew, birds, smoking history, and then what type of work they've done. And really, we're trying to understand if there's any signal for a pneumoconiosis. And then sometimes we'll ask about like unusual hobbies, in part because we're curious, like our ID colleagues, but also because things like spelunking or ceramics can also increase your risk of some of those things. But here, this is largely a negative history. And I think really important is to recognize that there's no medication exposures that would make us think about a drug-induced interstitial lung disease, which again, I think increasingly is becoming routine in how we screen patients.
Great. So basically nothing here that points to a diagnosis. So that
I will say that,
yeah, go ahead.
I will say that the move from Sacramento to Reno and the fact that she's now presenting with symptoms, that change in elevation is often something that also brings people to attention, where they feel fine at sea level and then they relocate just to 5,000 or 6,000 feet. And that change alone can reduce their ability to tolerate any additional insults, like an infection in cold and flu season, which brings them in.
That's interesting. Okay. 1 week prior to admission, she traveled to a high altitude area, I guess higher altitude, and developed worsening hypoxemia and dyspnea, now requiring 6 liters. Ultimately came here in July for acute on chronic hypoxemia and further workup of her newly diagnosed ILD. On exam, you see here normal vitals, respiratory rate 23, 100% on 6 liters, non-toxic, CHENT, cardiac exam normal, mildly increased work of breathing, bilateral rouse over mid-lung fields, intermittent cough, belly's benign, extremity swelling of both hands, non-pitting edema in both legs to the mid-shin, neuro is normal. And hyperkeratosis of both heels. And other pertinent physical exams found to have painful swelling of joints of the fingers and wrists, right deltoid muscle pain and weakness, and hyperkeratosis of palms and soles. So what do you think?
Well, I think so. In those buckets, right, we've kind of ruled out the exposure that becomes lower down. So now we're thinking about idiopathic or the autoimmune buckets. just looking at her demographics, being a middle-aged woman, the likelihood of a connective tissue disease ILD goes up quite a bit, right? And so we're really wanting for all patients, because actually when we anchor on those demographics, we often miss connective tissue diseases in older patients and in males. So it's important not to do that. And most frequently happens in the hospital. But for her, we really want to do that extra pulmonary exam, look at her skins, interrogate her muscles and her strength, and think about what screening serologies we want to send to get a sense if there's a signal there. I would say in terms of like the findings that are highlighted here, her mild increased work of breathing is not surprising, given that she's requiring 6 liters to sat 100%. The bilateral rouse and intermittent cough. So crackles, again, are most often finding that we're describing an interstitial lung disease. It sounds like Velcro, both in the inspiratory and expiratory phase. Cough is not surprising in these patients. One, because they may have a superimposed process, but even if there is nothing else going on aside from their interstitial lung disease, the scarring itself, when you take a big breath in, you're trying to stretch the lungs and the lungs are scarred, that triggers a cough. So that's very common. And then the hyperkeratosis and the swelling in hands and non-pitting edema, I think we're starting to think that maybe there is an inflammatory component or driver of this disease. And so makes me think about autoimmune diseases.
Okay. Anything more in terms of location or the
like,
hyperkeratosis or anything?
I feel like I'm supposed to know that's supposed to be triggering something, and it's
that's
not.
fine.
But I would say in general, the digits all seem quite swollen, and I'm not seeing any particular findings in the skin around the nail beds.
Okay.
We'll see.
Very good. We will see. All right. Get some initial labs. And CBC and lights are normal. CK is 989. UA is negative. LFTs are normal. LDH is elevated. Albumin's okay.
Again, I think probably the most helpful in these, LDH being a general signal of an inflammatory state here, and then CK making us think that there is muscle involvement in that inflammation. Often when we're sending screening labs, CK and aldolase are sent as a way of us trying to understand, is there muscle involvement in addition to lung involvement? And if there is, it makes us more worried about myositis. And so that's what I take from there. I would want to interrogate specific.
And so I'd say this is where those of us who don't do this for a living get in trouble, because I'm sure you could spend $100,000 on lab tests. What are the tests that you would want to get now based on what you have?
Yeah. So I would say we kind of have like the screening serologies, which is if I'm seeing you in clinic and I don't think that this is autoimmune disease, but I'm trying to do the due diligence to make sure I feel really comfortable about that. And then we have the serology we send on patients that we think this could really be an autoimmune disease. So the screening serologies are an ANA, a rheumatoid factor, often a CK or an aldolase, just to see if there's any muscle involvement. The guidelines for diagnosing IPF actually also tell you to send a myositis panel, which is like the most expensive study we can send, right? And it seems almost crazy that that would mean that we would send it on everyone. And so I think there's a lot of practice variability on whether or not there's enough signal there that we want to send it and if it's going to change management. Mm-hmm. I think in a patient like this, who right now is clicking a lot of risk factors and boxes for autoimmune disease, it is reasonable to send a more extensive panel. And so that's going to include sending serologies to test for antisynthetase syndrome, for myositis, so antisynthetase being a class of myositis. So those serologies you're going to send. There's nothing on her workup so far that makes me think about scleroderma, but we often will also send those also because the picture can be very mixed. And then rheumatoid arthritis is the most common interstitial lung disease that falls within the connective tissue disease space, and that's going to be a rheumatoid factor and anti-CCP.
Great. Okay. Let's see what they got. There's a whole bunch of stuff. I'm not going to ask you to explain what they all are. First of all, does this seem like a reasonable?
A very extensive and expensive workup.
Uh-huh. Mm-hmm. And was it reasonable?
We end up with a positive, this beautiful red one, which tells us this is So this is telling us that this patient probably has an anti-synthetase syndrome, OJ, antibody positive. It's not the most common one. The most common one is an anti-Jo, but O positive OJ and EJ are on there. I think generally what this is helpful for is we lean to our rheumatology colleagues a lot to help us, not so much with sending the serologies, because you could just send everything, but really trying to help us interpret the significance of a positive serology, because people can have positive serologies and no symptoms is suggested. And sometimes we're saying we're not going to kind of pay attention to this. And this patient, where we're already primed and concerned for an autoimmune disease, an extensive panel makes sense. And now we're worried that this patient may have an underlying anti-synthetase syndrome. And the reason why that is concerning is that these patients can sort of slowly progress along for months. And then all of a sudden, it's like something flips a switch and the disease is all of a sudden out of control. And so you're racing against the clock, not only to make a diagnosis, but also to get that patient on appropriate therapy, what often means hitting them hard with immunosuppression.
Okay, great. So you've told us that. So this is a summary. I'm not going to read it because I think I'm going to, if we have a sec, I'm going to read it to GPT after you weigh in.
Okay.
We'll see how it does. But the summary of what we think we have so far. So let's turn to you and say, you sort of already mentioned, but what do you think the diagnosis is here?
Yeah, I would, again, I'm worried about, generally, I think we feel pretty confident when we're doing those three buckets that now autoimmune disease is on the top. And this is where we work really closely. We're, grateful to have such wonderful rheumatology colleagues here to really sort of hone in on a specific diagnosis. And that's most easily done in autoimmune diseases because the antibodies can be very specific. So a positive OJ, I'm thinking about an anti-synthetase syndrome. This patient looks like on their CT scan, they have a mix of fibrosis and inflammation, which tells me that the disease has been going on for more than several months and that there is active inflammation. So the fibrosis, I'm not able to reverse. The restriction I see on those pulmonary function tests, that is reflective of the damage that's done. But the inflammation, that is potentially reversible disease. And that's where we work really closely with rheumatology to think about how hard and how fast are we going to hit with immunosuppression to not just to control the disease, but to reverse any inflammation and prevent scarring.
Right. So we'll try this. It will take 2 minutes and then we'll hear from one of your colleagues. So let's give it a try. This is GPT-5. Open evidence is better, but this one can speak to you. Let's see if mine is working. It does not seem to want to work. Now it's sleeping.
While you're doing that, did we know the progressive pain and swelling of the joints, wrists, and ankles? I feel like that wasn't shared in advance.
In the physical exam, there was evidence of swollen joints and the ankles, but not, I think, on history that I recall.
I don't recall it. I'm just.
All right. You're saying somebody kept that from you? Is that what you're implying there?
In the comparison with ChatGPT.
I'm just saying.
Might have
I say. Yeah, mine is not loading. So we'll maybe come back to the end. All right. First of all, thank you so much. That was fabulous. And we have Tim Deister here, who's assistant professor in the Division of Pulmonary and Critical Care and all those other things, and is going to teach us a little bit about this disorder. And so, Tim, why don't you come on up?
All right.
Next slide.
And so, indeed, the final diagnosis in this case was anti-synthetase syndrome associated interstitial lung disease. And so I'm going to do a little bit of teaching on this. And a lot of what I learned was from Dr. Farrand, who's one of my clinical mentors. So you'll see overlap in these slides with some of the things she said live in her diagnostic journey. So interstitial lung disease is a broad group of lung conditions. We heard there's over 200, most of which involve infiltration of the alveolar walls by inflammation, fibrosis, and/or cellular proliferation. And they can be, as Dr. Farrand alluded to, idiopathic, related to exposure, and I should add medications in that bucket, or due to an underlying connective tissue disease or systemic autoimmune rheumatic disease, which is a new term in the rheumatology literature. They generally all exist on a spectrum from inflammatory to fibrotic. And there are certain diseases that are more inflammatory or more fibrotic, but within a single disease, we can also phenotype them in this way. And IPF, for example, is the archetypal and most common fibrotic ILD. When we think about connective tissue disease associated ILD, there's many connective tissue diseases that have associated pulmonary manifestations. And this graphic, I actually had a clinic as a resident with Dr. Goglin and asked her, can you give me an overview of all of rheumatology? And true to form, she was able to do that as like a little sketch, which I have kept for years and years. And so this is a way to think through the relationship between different connective tissue diseases. The ones that I've marked with an asterisk, the inflammatory arthritides, ANA positive connective tissue disease, and the myositis would be the ones that are most commonly associated with interstitial lung disease, although many of these diseases rarely can have it as a manifestation. And specifically, the diagnoses within those buckets would be rheumatoid arthritis, systemic sclerosis, Sjogren's disease, mixed connective tissue disease, and then this final category, the idiopathic inflammatory myopathies, which would include polymyositis, dermatomyositis, overlap, the necrotizing form, and antisynthetase syndrome. So we're going to go ahead and zoom in on that specific circle here. And I will also highlight, along with Dr. Farrand's teaching point about the screening labs, up to 50% of these can be ANA negative. So it's really, really important that we don't use an ANA to rule these out, and we get that CK and aldolase that she taught us about. So let's talk a little bit about the antisynthetase syndrome associated ILD. We really love our acronyms. This disease posed a challenge, but we did find one that was acceptable to put in the formal literature. So we call this ASYS ILD. And you'll see that it's defined by the presence of an antibody directed against amino acyl transfer RNA or tRNA synthetase. And you can see that the 12 formal names listed in this table, or excuse me, the names listed in this table in the left column. And then on the right-hand side, you see the actual antibody that would show up on your panel. Clinically, these can have inflammatory myopathy. They can have interstitial lung disease. You can have mechanics hands, which is pictured here with the hyperkeratosis along the fingers, which I think Dr. Farrand was going up to the picture to try to see if we actually had it, as well as hiker's feet, which is a similar finding on the feet, inflammatory arthritis, and the Raynaud phenomenon. And ASYS-ILD can be indolent or rapidly progressive and can switch its phenotype, as Dr. Farrand mentioned. And the antibodies are associated with phenotypes, but they don't perfectly predict severity or rate of progression, again, alluding to the race against time that Dr. Farrand mentioned. So let's think a little bit through the diagnosis of interstitial lung disease. And so I'm going to actually display this slide in its entirety and then work my way back. So in an HPI, we may hear about chronic progressive dyspnea. We may hear about a cough. The exception here to it being a chronic progressive disease would be if it flares or rapidly progresses, which is a thing we see in inflammatory phenotypes, would be rapid progression. Flares typically occur in advanced fibrotic disease. We look for an exposure history, as Dr. Farrand had asked for, and that includes looking for organic antigens, birds, and specifically down. Asking about down pillows and comforters can help us look for a signal for hypersensitivity pneumonitis. The family history can be very important, both for fibrotic diseases, autoimmune disease, or for a history of sudden respiratory failure. Sometimes patients will describe that their mom or dad passed away unexpectedly and no one really knew why. That's another red flag. The labs that we would order are listed here as previously described, plus or minus an extended scleroderma or myositis panel. And then often we do see restriction with a diffusion defect on PFTs. The high resolution CT, as was discussed in the case, can be variable, and we'll look at that in the next slide. And then really importantly, these patients are often referred to us by general pulmonologists. So they'll come specifically to UCSF to have our physicians who specialize in ILD help assign a diagnosis in a multidisciplinary setting with pathology and rheumatology and radiology. And so I think that this slide was supposed to animate, but we're going to move through it without animation. So I want you to, with your eyes, kind of start at the top and think about these diseases as existing on a spectrum from fibrotic to inflammatory. And when we think about the fibrotic form of the disease, one of the archetypal examples of this would be idiopathic pulmonary fibrosis, which typically presents with this UIP pattern. It's subpleural, meaning it extends from the outside of the lung, and basilar predominant. You can see reticulation, which is thin lines that are a fine scar, traction bronchiectasis, which is the pulling open of the airways by those scars, and honeycombing, which visually looks like a bee's honeycomb and is a sign of more advanced disease. We think of this as being very classic in IPF, but we can also see it in fibrotic HP, in certain CTD ILDs, and with amiodarone toxicity. As we move over to the diseases that are, or the phenotypes that may be more inflammatory, we think about the NSIP and OP pattern. NSIP has subpleural sparing, so an inverse when compared to the UIP pattern, the edges of the lung are spared. It's bilateral, and you can see ground glass opacities. And then our final pattern would be organizing pneumonia, or OP, which also came up in the case discussion. And this would be peribronchovascular, meaning it runs along the bronchovascular tree, and it can have ground glass consolidation, hexagonal consolidation, or an atoll, which is that sort of round area of consolidation with central clearing. And this we see in some of the more inflammatory ILDs like connective tissue disease. And that's especially a concern, which I learned from Dr. Farrand, when you see an overlap of NSIP and OP pattern. Radiation exposure and drug effects are also things that can cause this. And then actually post-COVID, we sometimes see organizing pneumonia. That's a common complaint in the ILD clinic. And the reason phenotyping these diseases across the spectrum is really important is because it affects treatment. So when we think about IPF and progressive pulmonary fibrosis, which is a definition that Dr. Farrand is actually one of the experts helping us think about how to best define, our long-term management focuses on drugs that help slow down scarring. So nintedanib, pirfenidone, and the newest one on the block, very recent, nerandomilast. And you'll see the trials that show they had benefit listed there. When these fibrotic diseases flare, just like in other diseases we care for, there's a different set of treatments we consider. And in this case, the optimal management is actually pretty undefined. There's some retrospective data from our center that suggests that maybe steroids aren't so great for this, again, published by Dr. Farrand. And we as a field are not certain what to do when IPF or other fibrotic diseases flare. For inflammatory ILD, our long-term management focuses on immunosuppression. For almost all forms of this, the CellCept, mycophenolate mofetil, is the first line agent. And we then will add or switch immunosuppression if they're progressing through mycophenolate mofetil. For rapid progression, or for flare in this setting, we would use high dose steroids plus generally 1 or 2 additional immunosuppressants. And so when we think about this case in its entirety, we go back to December and this patient had dyspnea, cough, and sick contacts, but had a negative procal and RVP, which wasn't in the case, I don't believe, but it was true. Still got 2 antibiotic trials and then had this atypical chest CT. Following that, they returned and were found to have more ground glass, and a partial screening workup with ANA, RF, and CCP were sent, but they were negative. And at that time, there was no CK, aldolase, or myositis panel, highlighting the importance of those labs for diagnosing myositis ILD. They received prednisone and then developed other manifestations of their disease, including joint pain, which I apologize, Dr. Farrand was not in the history. And then an outside rheumatologist was consulted who wasn't sure there was antisynthetase syndrome, but the local pulmonologist wanted a second opinion, sent them to UCSF, and they were diagnosed with ASIS ILD. And to conclude before we do the experiment, the patient was admitted at this hospital, reinitiated on prednisone 40 and on mycophenolate mofetil. She completed an expedited transplant workup, but based on clinical stability with low-grade hypoxemia, was discharged home for a trial of medical management, continues to follow with both rheumatology and interstitial lung disease clinics. Her hypoxemia has stabilized, but her inflammatory myopathy remains poorly controlled, and she'll soon begin a trial of IVIG and rituximab.
Great.
Okay, I thought
Erica, why don't you come back up and make any comments that you want to make on this, and what would you think the prognosis would be?
I think twofold. One, in terms of prognosis, I think an important point to make is that prednisone is the one drug that we have in sort of our in our options that hits all of the organ systems of an antisynthetase syndrome, and so it's often included in the ultimate regimen. But we can't treat with high-dose prednisone long-term, right? It's why that patient did not get prednisone 60 for 5 months, because the side effects outweigh benefit there. And so then we're trying to look at a combination of immunosuppression. This is where managing antisynthetase becomes really tricky. A combination of drugs that's both going to control any muscle disease, any skin disease, and any lung disease, and balance the risk of infection or immunosuppressive risk that combination is going to have. So that becomes like the challenge and maybe the art part of this. I think there was 2 points that I wanted to make. One is that her illness script of sort of coming into a clinic with cough, shortness of breath, getting antibiotics, getting steroids, and getting inhaler is very common. And we get really frustrated, I think, in ILD when we look back and say, we could have made this diagnosis 6 months ago, 12 months ago. But the truth is the majority of people that come in with that do not have interstitial lung disease, right? So we cannot ask everybody to just send a high resolution CT scan, PFTs, and send them to ILD clinic right away. I do think what we can learn from that is that when we are continuing to treat someone in a way that we think is appropriate for the issue in front of us, and they're not getting better, that we need to expand our differential. And interstitial lung disease increasingly needs to be included that, particularly because we're recognizing it's not nearly as rare as we thought it was, that many patients have interstitial lung abnormalities, which is the precursor to this disease. So just thinking about it and maybe that next step of diseases that you think about when they come in. And then the second point I wanted to make is that this is one of the most common diseases that you're going to see in the inpatient setting that you're going to be involved in, right? Like many ILD patients, we're managing outpatient and they're only coming in if they have a flare of their disease. But these patients that can have rapidly progressive disease, right, can kind of be puttering along in the outpatient and present with acute hypoxemic respiratory failure. This is sort of an illness script that we need to be aware of on the consult service, and recognizing that early coordination with pulmonary and with rheumatology and with ID is really important for getting the workup done quickly that allows us to get them on appropriate immunosuppression and not let this sort of spiral out of control.
So I'll ask a question, but we have a few minutes to open it up. Role of transplant, and particularly in a disease that seems like a systemic disease?
The big barriers to transplant for these patients is that often they have not been diagnosed before. So they're coming in and getting newly diagnosed and worked up. And if they have extra pulmonary manifestations like muscle disease and they're weak, that becomes a barrier to transplant. So we have to make sure that we can control both their pulmonary disease and their extrapulmonary disease. Often transplant will be part of that inpatient evaluation. And frequently the response is stabilize them. If they can be discharged and get to clinic, then we can start the workup as an outpatient, often because if they are too debilitated when they're in the hospital, they're not going to be good transplant candidates. Mm-hmm. So looping transplant in to be part of the conversation, but often it's really careful sort of communication, titration of that immunosuppression between rheumatology and pulmonary. That being said, like if you're going to be transplanted, this is an absolutely fantastic place to get that done. And so we like to have transplant C patients inpatient so they can provide us guidance on modifiable barriers that we can address to give that person the best shot of getting to transplant should they need it.
Great. I think we have a couple of minutes. We'll see any final questions or thoughts people have. All our pulmonary colleagues are beaming, but anyone want to see the questions or comments? Really surprisingly silent. All right. Well, then with 2 minutes left, I will go ahead and see what GPT thinks about this. And I think I've gotten it to work. Let's see if we have. All right. Hello, GPT. I'm a doctor. We have a 52-year-old woman with hypothyroidism, hypertension, and psoriasis who has 6 months of cough, dyspnea on exertion, and progressive pain and swelling of proximal and distal interphalangeal joints, wrists, and ankles. She also has malaise and worsening of plaque psoriasis. High-res CT shows interstitial lung disease. She developed worsening hypoxemia and was found to have joint signs, as well as right deltoid weakness and hyperkeratosis of both heels. OJ antibody was positive and CK was elevated. What do you think is going on? And please be brief. We only have about a minute.
Absolutely. So in a nutshell, what you're describing really sounds like an autoimmune condition that's affecting multiple systems. The combination of interstitial lung disease, the joint pain, the skin findings, and that OJ antibody being positive, plus an elevated CK, all of that points toward an anti-synthetase syndrome or a related inflammatory myositis. So that's likely what's going on here.
All right. To be fair, we gave him or it more information than we actually gave you. Let me say thanks to Allison Bond, who put the case together. It was a terrific case. And Erica, thanks a lot. That was wonderful. Appreciate it.